Good afternoon and welcome to City Club of Portland's Friday Forum, Oregon's premier public affairs forum. I'm Sue Thomas, president of City Club, and I welcome you all, those of you here at the Governor Hotel, and those of you listening on OPB or KBPS radio or watching on cable television. Thank you for joining City Club today on Friday, October 2nd, for this week's Friday Forum. Today we welcome a panel of experts who will discuss the causes and spread of swine flu and its potential impact on the local economy and community. But first, some announcements. In consideration of those sitting close to you and those in our radio and television audiences, I ask that everyone in the room who has not already done so to please silence your cell phones. As always, we offer our appreciation to our Friday Forum corporate sponsors, whose generous financial support make these time-honored City Club luncheons possible. Please help me welcome our sponsors, the law firm of Baron Liebman and Zimmer, Gunsel, Frasca Architects. If your company or firm would like to sponsor a Friday Forum, please contact the City Club staff at the back of the room or call the City Club office. As I mentioned last week, the club is currently seeking volunteers for a new study committee charged with examining Multnomah County's practices for managing its mental health services. To learn more about the study and how to apply, you can speak to staff in the back of the room or go to the City Club website. City Club has 3 upcoming citizen salons and tickets are going fast. Please register on the club website to join an intimate discussion about the future of media in Portland, whether it's time for a change in Oregon's death penalty law, or to join in a bipartisan discussion about whether or not Oregon is governable. You can imagine there's a number of places that conversation could go. Next week, on October 9th, City Club's Friday Forum will examine efforts being made to improve Portland's school meals, as well as state and federal efforts to bring more locally grown food into our schools. And now on to today's program. In April 2009, Oregon identified its first case of H1N1 virus, also known as swine flu. As of this month, the virus has hospitalized at least 85 Oregonians and taken 12 lives. Swine flu presents a unique threat. It travels quickly between humans, its severity and long-lasting effects are difficult to predict, and unlike the seasonal flu, children and young adults are the most at risk. Today, City Club welcomes 4 speakers who will address the impact of H1N1 on Oregon. Our first speaker today will be LILLIAN SHIRLEY, Director of Multnomah County Health Department. There, she also provides public health leadership in collaboration with community partners to address the county's health needs and offer health policy leadership on both the county and state level. Prior to her work in Oregon, Ms. Shirley was the first executive director of the newly formed Boston Public Health Commission, and in 2008 was named a public health hero by Research America. Our second speaker is Dr. Mel Kohn. Mel received his PhD from Harvard and his master's in public health from Tulane before completing his preventative medicine residency here at OHSU. Mel has worked in the public health sector since 1993 and has served as an epidemic intelligence service officer for the Centers for Disease Control and Prevention as state epidemiologist here in Oregon. He now serves as acting DHS assistant director for the state public health division and is the state's health officer. We also welcome Dr. Gary Oxman as today's third speaker. Gary has served as health officer for the Multnomah County Health Department since 1987, and in 2007 assumed this role for the Washington and Clackamas counties as well. During his career, he has been involved in a wide variety of public health issues, including prevention and control of communicable diseases, and has recently worked extensively on local emergency preparedness and bioterrorism issues. Our final speaker today is Jean Baker. Jean first became interested in business district associations when she began writing the Long Division column for the Gazette and writing newsletters for Foster Area and 82nd Avenue business associations. She was eventually elected to the Division Clinton Neighborhood Board, where she served as president for 6 years before resigning in 2007 to become president of the Alliance of Portland Neighborhood Business Associations. With that, please help me welcome today's first speaker, LILLIAN SHIRLEY. Lillian?
Thank you, Sue, and thank you, City Club. Good afternoon. You know, when I first came to Portland and joined this community 10 years ago, City Club was a very important part of my learning and understanding of all the major issues and concerns on the civic agenda. So for us on the panel today, we really feel it's a testament to the seriousness and the focus being brought to bear on this issue, that City Club Friday Forum has put novel influenza on its agenda. So first of all, I want to say we have a plan. Public health has a plan to address this. It's multi-sectoral. It includes business, nonprofits, as well as all aspects of city and county agencies. It addresses the myriad complexities of this challenge, such as the vaccine itself. Where and when will it show up? Competing seasonal flu and the potential for real confusion in the community around that. The strain on our medical system, including ambulatory care, emergency departments, hospital bed capacity, equitable treatment and distribution of antivirals and other medical equipment. And not least, tracking the disease itself. Who is getting sick? Who is seeking medical care? How many are hospitalized? How many require intensive care? And ultimately, sadly, how many may die? And all this work will have to take place even if this virus does not change or cause more widespread severe illness than we have seen up to this point. For this response, there has been an unprecedented coordination from the federal level through the states and down through each of the approximately 3,000 local public health jurisdictions in this country. We have agreed upon goals across all these agencies. First, limit transmission. And second, get people who need it the care that they need. I had the opportunity on September 3rd to attend a meeting at the White House as a representative of local public health, along with several others from other jurisdictions and regions around the country. We met with high-level officials from Homeland Security, Health and Human Services, including their medical emergency preparedness directors from the CDC and from FEMA. This outreach from the feds, I would say unprecedented, illustrates the coordination and the dialogue that is taking place across the country, accompanying public health planning and response to this nation. So here in the Northwest, what does our preparation look like? We'll be going into a lot more detail with Dr. Kohn and Dr. Oxman, but I want to give you a little bit of an overview of the types of activities that have been happening. We've established unique partnerships going back to our emergency response preparedness work that began in 2004. And these are with schools, with child care networks, with business organizations, and community-based organizations, including providing for those organizations technical assistance on planning, holding actual exercises, and targeted communications around what is the message that what audience needs to know and hear and when. We've partnered with OMSI and Science Pub, and we'll be doing this again on November 2nd. We've partnered with the Multnomah County Library around a children's curriculum to match the H1N1 issues, as well as collaborating on Everybody Reads for this year's book, which was similar than the Everybody Reads book that we worked with them on in 2007. So there's been a strong foundation around the work that needs to be done now in response. We have a Health Reserve Corps, which is regionally recruited, that works across the counties to coordinate volunteer health professionals that will be needed for this and other events that will require us here to have a large community response. And a few years ago, we convened a group of community organizations serving ethnic and immigrant populations around emergency preparedness, and that included pandemic flu possibilities. This is known as Communities United for Emergency Preparedness. They conduct training and exercises within their group, and we funded them to conduct outreach to their own communities for trusted messaging, if and when needs arise. Our current response activities are together with Washington and Clackamas County. We have a tri-county coordination group for public health policy development and oversight of regional activities around flu. So this includes not only working regionally to plan for vaccine distribution, it includes jointly funding positions across the region, so we will have the most efficient as well as the most effective response. And most importantly, we have a strong focus on access to care for people with no regular medical provider or no insurance. This is a robust collaboration among safety net clinics, individual physician providers, hospitals, and healthcare systems all across our region working together to respond, identify the need, and fill that gap. And we also have regional public information. We have coordination of messages and media strategy that works not only in our region on the local level, but also with the state. And included a regional email list for media, elected officials, and over 800 community leaders to get information in a timely way. We hope that this will ensure all of you here today listening to receive the same information from a reliable source without delay and without confusion. So we're collaborating on all levels of government, and we're leveraging our community partnerships. And to accomplish that goal that we hold together, limit transmission and get people that need it into the care that they need. Next, I'd like to turn this over to Dr. Mel Kohn, who will address the basic overview and the epidemiology. He'll talk about what happened in the spring and what we can expect to happen this fall and how you can help us. Thank you very much for your time and attention.
Thank you, Lillian. It's a pleasure to be here today, and thank you to the City Club for making this possible. As Lillian said, I'm going to give you some background on what happened last spring and what we are expecting to take place this fall. We've been planning and talking about the possibility of a flu pandemic for many years. We know that flu changes a little bit each season. The virus itself changes, and that's why you need to get a new flu shot each season. But every once in a while, and how often this happens is a subject of great scientific debate, the virus undergoes, for reasons no one fully understands, a very major change. And when that happens, everybody becomes susceptible, and the potential for a very widespread epidemic becomes real. When we have a widespread global epidemic, we call that a pandemic. So we have had pandemics and pandemic threats since 1918 is the first and probably the largest pandemic that has been recorded. It's kind of the disease catastrophe against which all other epidemics are measured. Over 500,000 deaths here in the United States. Very, very large number of people worldwide, 20 to 40% of people worldwide who came down with this illness. Very, very difficult time. And we have been concerned that will the next pandemic be like 1918 or not? That's kind of the specter that hangs over all of our considerations in this area. So last spring, when in April, when the reports of people ill with a new variant of the virus, which got labeled a swine flu, we're now referring to as pandemic H1N1 flu, because the virus actually contains more than just swine genetic material. It also contains genetic material from human flu viruses and bird flu viruses. So this new strain appeared, and coupled with reports from Mexico that were initially very alarming about high rates of disease and death, this really rang all the alarm bells for us. And I remember going to our departmental cabinet meeting where we all kind of go around and give an update. And when it got to me, I said, well, the public health world is about to be turned upside down. And people kind of looked at me like I was exaggerating. A week later, nobody thought that I was exaggerating. And it was really quite a whirlwind. And we are still, I think, at a really historic place for our public health system. So what happened last spring, however, was that very rapidly information changed as we got better information from Mexico. And I really want to applaud the Mexican health authorities for sharing the information that they had as soon as they were able to collect it and verify it. As we got more information, we were able to appropriately ratchet down our response. Initially, we had been quite aggressive, for example, about closing schools, but it soon became clear that the illness from this new strain did not appear to be any more severe than the illness from the seasonal flu. Now, you have to understand that while many of you may not think of flu as a serious health threat, from where I sit, it very much is one. Every year, about 10% of the U.S. population gets sick with flu in a typical flu year, and there are about 36,000 deaths a year in the United States. So this is a serious illness. The prospect that maybe 3 or 4 times that number of people would get sick, that would mean 3 or 4 times the number of hospitalizations and other complications, including death potentially, was a very, very alarming one for us, even without any more severity to the illness itself. But it became clear, I think, as we collected some more information, that this illness did appear to be of the same severity as our seasonal flu. And so we started to treat it like that and ratcheted down our response appropriately. Typically in the summer, flu takes a vacation, again, for reasons that nobody fully understands. There are a lot of theories, some with evidence, some with not. But nonetheless, we were expecting that the flu was going to go away over the summer. But in fact, this new strain of flu has not taken a summer vacation. We've continued to see cases through the summer, and towards the end of the summer started to see an uptick in cases, particularly in the last week or two. Since April of 2009, we've had 164 hospitalizations here in Oregon and 15 deaths. And I am expecting those numbers to increase, as I said, because as we get into the typical flu season where the environmental conditions promote flu transmission, and as we are, for example, kids coming back into school, that's a place typically where a lot of transmission happens. As all of those things get into place, we are going to, I believe, start to see more and more illness. So what's our response to this? Well, vaccination really is the best tool that we have. And I know you're going to hear in a lot more detail from Dr. Oxman about the vaccination plans here in the metro region. I will tell you that we are focusing our vaccination plans on reaching particularly those groups that seem to be particularly affected with this H1N1 strain. They're a little different from the groups we see in a typical seasonal influenza year. In a typical year, it's folks at either end of the age spectrum, those above age 65 and young children who are particularly affected. What we've seen with H1N1 is that children and young adults seem to be the groups that are having the highest rates of illness and the highest rates of complications and death. So the priority groups for vaccination are based largely on that, and they include pregnant women, children and young adults between 6 months and 24 years of age, caretakers of children under 6 months of age, because children in that age group do not respond to the vaccine, so the idea is to kind of vaccinate around them in order to protect them. People from 24 to 65 who have chronic medical conditions that put them at risk, and then frontline public safety and law enforcement officers and healthcare workers. The thought with healthcare workers in particular is that they're often interacting with people who have various vulnerabilities. Obviously, people who are sick come to see healthcare providers, and we don't want healthcare workers to be the vector for spreading this disease. So we ordered this week our first shipments of vaccine. We're expecting that next week they're going to start trickling in. And I want to say one thing very clearly for our listeners. There is no requirement or mandate for anybody to take this vaccine. I very much see our job at the state and local level as putting out information so that people can make as informed a decision they can, weighing the real risks from not being vaccinated. As I've told you, I think we consider flu a serious illness against whatever their concerns might be about taking the vaccine. Continuity of operations planning in the business community, I'm very pleased that Jean is here today to speak about that. I think that's going to be critical to minimizing the impact that this is going to have on our economy and on our lives. Finally, I want to close with just a few challenges that I think we face. The primary one, I think, is one of logistics around getting people vaccinated. If you add up the number of people in the priority groups that I mentioned to you just a minute ago here in Oregon, that adds up to almost 2 million people. That's a lot of people to get vaccinated. I can tell you that nationally, last year we gave 130 million doses of seasonal flu vaccine. Secretary Sebelius has said that there is going to be enough vaccine to vaccinate 300 million people. So this is a substantial increase that just handling the logistics of that is an enormous challenge. And our local health departments have primarily been the focus point for doing that, figuring out how best to do that in each county around the state. They're doing a terrific job. Second, I think matching the demand of the vaccine to the vaccine supply. I mentioned we are going to be getting doses of vaccine in the state next week. Some counties will be getting as few as 100 doses of vaccine. Now, I think it's a bad idea, and I say this is just in the first shipment. We're expecting we're going to continue to get more, and by mid to late October, we should have enough vaccine to fully ramp up our vaccination clinics and other efforts to get it shot in people's arms, and we have some flu mist as well that will be sprayed in the nose for some groups as well. But I think the issue of matching the demand for the vaccine with the supply we have is a challenge. If I were to put on a flu clinic and had only 100 doses, there was a large demand for the vaccine, you could imagine the crowd control issues we would have around that, very, very serious. So I want people to want to get vaccinated. I want to tell them that this is an urgent thing, but I also want to be realistic about taking the time for the supply to match that. We're pushing the vaccine out as soon as we get it. There is no delay from us. It just takes time for it to be manufactured. And then finally, I think the last really large challenge we face is around communications. How do we walk that line between making this an urgent priority for people, but not making people panic? How do we give people good information that they can use and combat what is going to be, I'm sure, there already has been to some extent a lot of misinformation out there, particularly in an environment where things are changing so rapidly. I mean, just to give you an example of this, on Wednesday when we ordered the vaccine at about 8 in the morning, I was told that we were going to order this particular amount of vaccine. 30 minutes later, somebody told me, no, that number was off by about 10%. So this is the way that things are changing. There are a lot of moving pieces to this whole apparatus, and we all have to kind of surf with the waves that come our way. And in that regard, the last thing I want to say is that we do have our website, www.flu.oregon.gov. We think this is the place where we are going to put the most up-to-date information we have, the most up-to-date guidance. So if you want to know what's happening, that's the place to look. We also have a hotline number that we are in the process of ramping up, and that will be another place where folks can call and get information. But the website really is going to be the cornerstone of a lot of our communications. So with that, I will turn the podium over to my colleague, Dr. Oxman, and Gary.
Good afternoon. It's a pleasure to be here, and I thank the City Club and I thank you all for coming this afternoon. I'm going to speak a little bit more about what's happening more on a detailed level, how we're actually implementing some of the activities that Lillian Shirley and Mel Kohn talked about. In an operational sense, there's really three things that we can do, three primary strategies that we employ in public health to confront the H1N1 epidemic. The first is preventing illness through trying to assure appropriate behavior on the part of people and the organizations in which they live. Preventing illness through vaccination, as Dr. Kohn mentioned and Ms. Shirley. And also providing appropriate medical care for those who escape the effectiveness of prevention. So those are our primary strategies. We also have a couple of supporting strategies, public information so people are well informed, and then what we call public health surveillance. So let me get into these in a little bit more detail. Preventing illness through appropriate behavior. I'm sure you've heard the public health mantra. Wash your hands, cover your cough, stay home when you're sick. Okay, everybody, wash your hands, cover your cough, and stay home when you're sick. We can't really act out staying home when you're sick because it's not quite as simple as washing your hands or covering your cough. And that's one of an important point that we need to realize. In order to do a simple thing like staying home when you're sick, people need information. They need to know that that's the right thing to do, but so do their family members, their friends, their peers at work, and most importantly at work, their supervisors. We also need institutional support for that to happen. And so it's all well and good to say stay home when you're sick, but if you don't have the appropriate supports at work, you can't stay home when you're sick. And in public health, we often talk about the choices that people have are limited, or the choices that people make are limited by the choices they have. And if you don't perceive yourself as having a choice, it's really not a choice. So for example, if you're working in a workplace where you're told you better show up or you're getting fired, or you're not getting paid if you don't show up, or if you don't have sick leave, that really affects people's behavior a great deal. And so the institutional component of those messages is really critical. And what that comes down to in many cases is policy that happens within our government agencies, within our community organizations, and most importantly, in our business organizations. So, you know, if your HR policies are not lined up to allow people to stay home, they're not going to stay home. And you are going to suffer having a lot of sick people in your workplace or your school or your agency. So our second public health strategy is preventing illness through widespread availability and widespread uptake of vaccination. And I think it's important to articulate that vaccination is really based on a social contract for the common good. We vaccinate ourselves to protect ourselves, and we also receive vaccination in order to protect our community and our fellows. We believe, as Dr. Kohn said, that vaccine is going to be plentiful. It's just not going to be plentiful all at once. So we're getting these small shipments to start with. It'll ramp up rapidly in the coming few weeks. So that really requires that we start out really trying to vaccinate folks who are in the identified priority groups. We see our responsibility in local public health as making sure that there are multiple pathways through which people can get vaccinated. The choice of vaccination is a voluntary choice, and we, again, want to make the right choice the easy choice for people. And so what we'll be doing is providing vaccination as a community through lots of different channels. Private medical providers certainly will be involved in a very major way. This includes hospitals, it includes independent practitioners, our large health systems, and managed care organizations. Schools will be our partner in vaccination, and in the metropolitan area you'll see lots of variations on these themes. Different forms of vaccination or different approaches to vaccination designed to reach school children and their families and community members. They'll be carried out differently, but they'll be there in all 3 counties in the metro area. Use of commercial vaccinators, and this is not an advertisement, but you've heard of groups of getaflushot.com, things like that. They'll be part of the strategy as well as commercial pharmacies in the community. Community-based organizations will also be central in our strategies. We're working cooperatively with groups like nursing schools, community-based organizations, various volunteer organizations in the community to partner with public health, and where they'll really be providing a lot of the service, we'll be providing the support and the organization for it. And finally, there will be public health vaccination sites. Some of these will be available to the general public. Others will be focused on particular populations, whether they be populations with special needs like homeless folks or populations with linguistic needs, non-English speakers, et cetera. The bottom line is that vaccination, again, has to be easy, it has to be acceptable, and it has to be fair. Everybody has to have a fair chance of getting vaccinated if they want one. Excuse me, that was a little demonstration. We have to take every opportunity to reinforce these messages. Our final strategy is providing appropriate medical care for those who become ill despite our best efforts to prevent the illness. And you know, we do need to grasp the reality here that despite our best prevention efforts, people will become sick. Some will become very sick and require hospitalization and intensive care, and unfortunately some will die. And that's just a reality we're going to face no matter how good a job we do. So our challenge is to do our best to make sure that the medical system provides services to the people who are really in need so we can prevent those complications and deaths. And we're really talking about 2 fundamentally different approaches. One approach is to make sure that our mainstream medical system serves those who already have good access to care. You know, if you're insured, you know, I'm well insured, and if you have a regular place to go to get care, that's where you should be getting, your care. And the public health function to support that is making sure that those hospitals and clinics and clinicians are all well informed. They know how to diagnose you, they know how to treat you, they know where to get the drugs and supplies they need to do that, and they carry that activity out effectively and efficiently. The other approach is to create a new and limited approach for access to care for those folks who aren't well served by our current system. And that's really for low-income people who are underinsured and uninsured. So we are not trying to fix the entire healthcare system. We have people in Salem and in Washington, D.C. who are working on that. What we're trying to do is just make sure that people in the community don't suffer the tragedy of becoming critically ill and dying because they couldn't find somebody to talk to get reliable medical information, or they couldn't find some place to get a medical examination and treatment in a timely fashion. So our approach here is based in partnerships. We're working side by side with the state on this. We're using federal assets to support this. And so we have all levels of government, the federal government providing resources, state government providing resources and consultation and advice, and then partnerships among the 3 metropolitan area counties to do this. It also involves partnership with our private sector healthcare providers. And so we're working with hospitals, with managed care organizations, with community-based organizations, with safety net clinics to knit together a system where people can call, they can get reliable advice, they can be told how to take care of themselves at home, and if they need care, they can be referred to an appropriate source of care. And if they have insurance, they'll get referred to their own provider or another provider that they can afford to see. If they don't have insurance and they're low income, they'll get referred to some contributed visits that we're working with all our medical providers on. And we hope to have this system up and running by the middle of October. And we're confident that we'll get there and we'll provide support to a lot of people that way. I also just wanted to mention a couple of the supporting strategies. The first one is what we call public health surveillance, and this is not the stuff of spy novels. This is the ordinary shoe leather epidemiology that public health departments do all the time. And as LILLIAN Shirley stated, it's about understanding how many people are ill, how severely ill are they, where are they in the hospital, are they in the intensive care unit. And our purpose in doing this surveillance is really to understand what's going on in the community so that we can inform the community, and also so we anticipate where things might be going. So for example, if we're aware that most of the intensive care beds are being filled up, and we're also aware that illness seems to be really progressing rapidly in the community, we can take some actions with our hospital partners to make sure that they manage their resources appropriately, and we free up the intensive care beds we need in order to serve the community. The second supporting strategy is public information, and you'll be hearing a lot from public health in the coming months. This is part, what we're doing here today is part of public health trying to be visible and trying to get information out. But you will hear national advertising messages from the CDC and Health and Human Services. There'll be a state campaign of public information. You'll be seeing local messages. And basically, we intend that all these messages will support community members in being well-informed, understanding the choices they have in front of them, and making the decisions that are appropriate for them as individuals in the context of their families and their communities. So just to close, I just wanted to say that the H1N1 pandemic represents a very serious challenge to the health of our community, but it's a challenge that we are well prepared for. We've been working for years to get prepared, and we believe that we're well prepared to meet that challenge. So thank you again. And one thing, an example of our public information efforts, there's a handout here that you can get today, and that tells you more about what we're doing here in the community. So thank you again. And I would like to turn the podium over to Jean Baker, who will give you a small business perspective. Thank you.
Good afternoon, and thank you. It's a little difficult to come and talk to all of you about our response to all of this when I have heard of all this careful planning and we are still in the very chaotic stage. But I'll start out with, I'm Jean Baker. I'm the president of the Alliance of Portland Neighborhood Business Associations. For obvious reasons, we call ourselves the apnba. It's easier on everyone. And I'm going to talk about the difficulties that the small businesses are facing with the threat of the swine flu this year. First, a bit about who we are. The apnba is the umbrella organization for the business district associations that exist on the main streets, the town centers, and the industrial districts that surround the downtown Portland. We support our member districts by providing grants, technical help, networking, advocacy, and as in right now, lots and lots of information that we are getting from the county and the city about what they're supposed to, what their choices are. Although you may not be familiar with the term Business District Association, you undoubtedly know some of us by name. We're the Pearl District, Hawthorne, Historic Mississippi, Central East Side Industrial District, and of course the Columbia Corridor, which is larger than Troutdale. The apnba indirectly serves between 35 and 40,000 small businesses in Portland, the majority of them with 10 or fewer employees. This fall, the small businesses are presented with some overlapping problems. The rapidly, efficiently spreading swine flu expected to last 10 to 12 weeks. The holiday shopping season guaranteed to last 10 to 12 weeks. The lingering effects of last year's disastrous shopping season on most of the small businesses, and the current economy guaranteed not to recover in the next 10 to 12 weeks. So here you are, you have 10 people, you have a small retail store, you don't have health insurance for your people, you cannot close because you have to make money this year. Absolutely necessary that you get through the season to survive it all. And unless all of you haven't been out of your houses, you have seen the empty storefronts of the ones who haven't made it. So this is a huge, huge priority, and it is driving all of the decisions that they are making. So there is tension between this need to stay open, to have a successful season, to recover financial control, and the need to provide for the health and the safety of their family, their employees, and their customers. The majority of small retail businesses earn the majority of their annual income during the holiday season, so this is just very, very important to them. Given the tight money market, many of the small businesses see the holidays as their last chance. And it's putting considerable tension on them when they're thinking about 40% of their people gone, 50% of their people gone. So OSU says that the flu bug stays on doorknobs for 5 days and on money for 10 days. People can understand this. It's very simple. So obviously, you keep your doorknobs cleaned off and you look into whether or not you can microwave your dollar bills. But that means no handshaking, no quick hug, none of the common civilities that you offer your valued customers. And to give you some idea how difficult it is, this was a swine flu discussion. A lot of you out there are professional health professionals. How many of you shook hands with people when you walked in the door? Okay, you see the difficulty. Okay, businesses have reported it on Hawthorne. I got the first of the emails. They have the swine flu on Hawthorne. A half a mile away, the next day I got to notice that they have the swine flu on Belmont. Another half a mile in the other direction, I got the information we had the swine flu on Division Street, and it's suspected on Historic Mississippi, way over in the northeast end of town. It's here, and it's affecting us, and we now have to do something. They've chosen to deal with this with instructions they have been given. You know, wipe your hands, clean your counters and your doorknobs. Some of them have considered closing the public restrooms that they have in their stores, or that they make available to the public. They have moved the wastebasket from right next to the sink to right next to the door. So when you wash your hands and you leave the bathroom, you are not touching the doorknob. You still have your towel and your tissue in your hand, and you have someplace to dump it afterwards. Some businesses that don't offer health insurance, and this is a majority of our small ones, are offering either 2 free sick days or that they will cover the cost of the swine flu shot when it becomes available for their people. And some of them, which have high school and young college students as most of their staff, are the ones who are offering the swine flu shots, because these are the ones who are the most vulnerable and the ones least likely to have any kind of health insurance to cover them. None of the businesses are considering closing. The apnba office, actually, its plan is, we have one person in the office, the executive, the rest of us work from our homes. The executive director has somebody to back her up. If that person's not available, we will just go online and close the office down until somebody's healthy enough to be back there again. But we aren't selling to customers, so it's possible to do. They're insisting that the sick people stay home, and it doesn't matter what it looks like you're sick of. If you come in, you're coughing, you're sneezing, it could be a cold, it could be an allergy. If you look like it, they say go home. Don't even come in. So how do you stay open long hours, keep the store looking good, handle the transactions, manage your security with half of your staff out? How do you hire and train temps if you are not there? What if your employees are these vulnerable 16 to 30-year-olds? How do you manage if you absolutely have to stay open because you say you're the grocery store or the corner Quick Mart or your pharmacy store and you have to be there? How do you pay your temporary workers when right now your budget is in the minus and you're living off of your credit cards or some small loan you got? At one of the martial arts schools, the students and instructors are now required to wash their hands with soap and water or hand sanitize before and after classes. They've added hand sanitizer dispensers to the class area so the students can wipe their hands excuse me, easily during class. And they have decided that this is such a good idea that this is not a swine flu thing, this is a requirement from now on. They have made it a permanent thing. One of the people who works at home says, I go out only when I'm doing appointments because I'm working out of my house. I take personal responsibility by staying home. I use hand sanitizer I carry in my pocket. When I'm riding on Max, shaking hands at chamber or civic meetings, I sanitize and wash my hands and face after I leave. A senior community has sanitary items in place, and they are urging the seniors to go see doctors. And one of them says, we encourage you to stay home if you feel just a little off. Don't even wait till you're sick. If you think you're coming down with it, stay home. We're set up to work from home. We've given 2 extra days of sick leave. And it's important for me to keep passing out to all of these people not to overreact until something actually disastrous happens, and it may not. There's the chance, excuse me, that it's not going to be a pandemic. Maybe it's just going to be a really severe flu season. Maybe you're going to be able to keep your doors open. Maybe the bank is going to give you a little bit more money because things are going bad, If you weren't risk takers, you wouldn't be entrepreneurs and small business people. But some people have put up this. I'm sure you can't see it, but it's a picture. It says, blow your nose, throw away the tissues, cough into your arm, wash your hands with soap and water, do it all the time. And they've posted it at the counters, they've posted it in the break room, they've posted it in the restrooms, they've posted it just about every place they can without being too obvious. And for the rest of it, they're going to wait and see. So, if you are not seriously ill with something, please go out to our local shops and go shopping.
The first question for our speakers, as always, will be from our City Club host. Our host today is Leslie Moorhead. Leslie is a consultant providing financial management services for small businesses. She joined City Club in 1978, served on the research board from 2002 to 2008, and is currently the secretary of the Board of Governors. Leslie?
Thank you, Sue. Well, you've all convinced us, if we weren't convinced before, this is a serious health issue. And it's also a serious worldwide public policy issue. So I want to ask you this question. Do you think any countries or jurisdictions within countries around the world will require, that is, mandate, that citizens be vaccinated against H1N1? Would this be a good idea, and if so, in what circumstances?
Thank you. So, do I think that any countries around the world are going to require mandate vaccination? I haven't heard about countries that are going to do that, but this is really kind of a question, I suppose, about political culture and how you approach these kinds of problems and how prescriptive you want to be about them. So we in the United States value very much our individual choice and individual freedom. And I think to put such a mandate in place, particularly in a widespread way for people, would be something that most people would find very, very difficult to accept and accommodate to. Now that said, there may be situations where we would want to have that discussion with the community about wanting to do that, but things would have to get really quite dire before I think we would get to that place. However, we certainly do want to encourage people to get vaccinated, and I would say particularly healthcare workers, where this becomes an issue, and really it's an issue for all of us, not just about protecting ourselves, but about protecting our community. If enough people get vaccinated, we can really change the trajectory of this whole epidemic. And I think that's a very important responsibility that we all have, not only for ourselves, but for the greater good as well, the business community, and so forth.
We'll now take questions from the floor. Asking questions is a privilege of City Club membership. When you ask your question, please identify yourself as a club member and ask your question in 30 seconds or less.
Ted Kay, City Club member. It must drive you absolutely bonkers when you see AOL's headline, "Girl Gets Vaccine and Dies." Would you comment, A, on the content of that particular case, and B, most importantly, what the public relations reaction to that ought to be?
I just assumed that was me. I think that we have to be very realistic about all of this. And everything in medicine is always a question of risks and benefits. Because we see flu every year, I think we tend to discount its seriousness. And the report of this terrible thing that happened to this girl, I actually don't know the details of her case, so I can't comment on that for you. But obviously a horrible thing that happened to her, if, assuming that the reports are correct. I think you have to put that in context and weigh that against the threat that you have from not getting vaccinated. As we hear about any complications from vaccination, if any should develop, we will be providing that information as aggressively and realistically and accurately to the public as we can. That's an important part of having the information you need to make the decision about getting vaccinated. But I think we have to be really careful about the sensational and put that in the context of the risk of not getting vaccinated. I can tell you on a personal level, for me, my children are going to be in line to get vaccinated as soon as vaccine becomes available in our community. I feel that the vaccine is safe, it's been tested, and I want my kids to be protected. And I guess that's the best statement of my own belief in what I'm saying that I can possibly give you.
Susan Pierce, member and healthcare provider. I'll admit to being over the age of 60. I know that, and my employers already have the flu vac schedule on the wall. We've read that the H1N1 vaccine is going to require 2 vaccines. And then sometimes we're reading that maybe it'll only require 1, at least for some people, in addition to the usual flu vac. So my question is, who needs how many vaccinations and at what interval? I'm sure other people are wondering. And how is that going to be organized among the public health institutions?
Initially, it was thought that two shots or two vaccinations would be required for the H1N1, based on our previous experience that when people are dealing with a new vaccine, they often need a priming dose and then a booster dose. The good news is that the research that's been carried out on the vaccine showed that people actually have a very robust reaction to the new H1N1 vaccine. So adults and children down to the age of 10 only need a single dose to be protected, and that's based on the scientific evidence we have so far. And then children 9 years of age and less will require 2 doses, and again, that's supported by the evidence, the testing.
And the H1N1 vaccine can be given simultaneously with the usual flu vac, is that correct? So it takes one encounter?
In most cases, yes, there is one combination where you wouldn't want to give the live seasonal flu vaccine, the nasal spray for the seasonal vaccine, and the nasal spray for the H1N1 together, but otherwise you can combine them. So yes, if people want to be vaccinated at the same time, yes, we can find ways to do that.
If I might just add to Gary's comment that for kids who do need 2 doses, those need to be spaced 3 to 4 weeks apart.
Kurt Wabering, member. I'm fortunate to have a government-supported health insurance. I'm on Medicare. And so when I went to get a flu shot, it was free, the earlier shot. So my question is, for the H1N1 vaccine, for the ordinary person who doesn't have insurance, what's the likely cost? And what's your speculation about whether, if we had national health insurance, what the likelihood of everybody getting one?
So the vaccine has been purchased by the federal government. I was going to say it's free, but really we've all paid for it already is the point. There's no additional charge for the vaccine itself. However, there is still some discussion about the ability of private providers to charge an administration fee, because there is some overhead to administering the vaccine. You have to have an office, you have to have somebody to give the vaccine to the patient, and so forth. I think there is going to be that provision coming from the federal government in terms of tied with the provision of the vaccine. However, I should also say that nobody is going to be turned away for inability to pay for this vaccine. There should be places in every community where people who don't have the means to pay, don't have insurance that will cover this, can go to get their vaccine. And a lot of the local planning has been around that very issue.
Thank you. I just hope those administrators are not being advised by Ticketmaster.
Mike Radway, City Club member. I know that hand washing is a first line of defense against the virus, but a second line of defense is obviously sanitizing surfaces, but I've heard conflicting reports as to how long the virus can live on an inert but commonly touched surface. Can you give us guidance on that, and also what are considered effective sanitizing techniques?
The virus can live on surfaces for minutes to hours. The question you have to ask is how likely are you to be exposed? And so, first of all, just normal cleaning that you would carry out in the normal scope of your business activity or home activity is probably adequate. If you want to supplement that by increasing the frequency of cleaning for areas that are high touch. So for example, in a workplace, if you have a shared computer terminal where everybody's typing on the same keyboard, if you have doorknobs or in some cases escalator rails that people are constantly touching, an enhanced cleaning schedule is reasonable for that. But I think it's important for people not to get too distracted by taking care of the environment, because there are other important things to do too, like covering your cough. and washing your hands. So reasonable cleaning, enhancing it a little bit, but let's not go overboard.
Hi, Leslie Lewis, City Club member. I'm a small business owner. I interact with the public pretty frequently. So it sounds to me like you would recommend that I, wanting not to be, as you said, a vector, I should be immunized. Okay, that's the first part of my question. Second part is, from a business standpoint, is there a possibility that so many people might be taken down by this that businesses would be well advised to talk to people they know who could volunteer to step in their place, healthy people, to step up to become their labor force if half of their labor force is taken down? Is that something you'd recommend?
Yes. Yeah, the question of doing, of having volunteers come into your business place, there's all kinds of, labor standards issues with that. But the idea broadly of continuity of operations planning, where you're saying, okay, I have a business, I have 10 employees. If I'm down to 8, I can probably do okay as long as it doesn't last too long. If I'm down to 7, I'm going to need some help, or who am I going to need to cross-train? Those are the things that you should be looking at right now. And that would include, do I need to bring on temporary workers, or if you're in a volunteer situation, do I need to bring on additional volunteers, et cetera? So I don't know if others have things to add.
Many of the small businesses are already busy cross-training, getting a hold of their neighbors or relatives, finding out if the hardware store man next door has a son who's home for the vacation, so you know who might know enough about business that you don't have to strain from scratch. It helps a whole lot if your volunteers, for instance, know how to use a cash register. But they're doing what they can to stay within their communities and find ways of supporting themselves just in case.
I just wanted to add one other thought to this business continuity planning discussion. And I don't want this in any way to minimize the serious challenges that Jean described for small businesses. But there may be some opportunities there as well. We had the governor sponsored a summit in August on flu. It was very well attended. We had a breakout session on business continuity planning. And on our panel was a restaurateur who said, maybe there are some opportunities here for us. Maybe we should be marketing a flu menu. When he said that, I thought, what does that mean? Are you going to serve flu to your clients? And what he meant was, well, chicken soup, comfort food. So there's a marketing potential there. Another idea he said is people may not want to come into the restaurant because they're concerned, are they going to get ill from their friends around the table or the servers? So maybe we should be ramping up and marketing our takeout menu. Or maybe they're not going to want to come in because they're feeling ill, they want to stay home, but they could run out and pick something up. So I would encourage people to think very creatively about how this might be an opportunity for your business.
Lisa Kaskin, City Club member. I was wondering about the nasal vaccine, actually both for seasonal flu and H1N1. I'm wondering, is it killed or attenuated? And I'm wondering, because of immunocompromised folk, and what difference that might make for them being exposed to it.
The nasal spray vaccine is a live attenuated vaccine, so that means it's weakened, but it is a live vaccine. For that reason, it's not recommended for pregnant women. It's also only licensed for people between the ages of 2 and 50, 2 and 49. And there are some other folks who may have some kind of immune compromise for whom it probably would not be a good idea. So there are some restrictions on its use.
People who are immunocompromised to be around someone who has gotten that vaccine.
There's some theoretical concern about that, but in reality, we think that's a very, very small risk. For healthcare workers, for example, healthcare workers who work, let's say, on a bone marrow transplant unit, it's probably not the best choice for them. On the other hand, if it's that or nothing, probably better that they take it, number one, and then be more careful about their hygiene at work. And in addition, for other healthcare workers who wouldn't be closely interacting with people who have severe immunosuppression, it's probably just a fine alternative for them.
Lonnie Tucker, and I am a City Club member. I'm asking this for someone at the table. On availability, will it be staged with the priority group and then available to everyone, or how will that work on the vaccine availability?
Initially here, the vaccine is coming in a trickle. Within a few weeks here, it's going to be a substantial stream of vaccine coming in. So what we're recommending is that people who are in the priority groups be vaccinated first. It's not going to be a highly, as the vaccine becomes more available, I think the message that we really want people to have is we want everyone who wants to be vaccinated to get vaccinated, and we will pay less and less attention to the priority groups as the supply becomes more abundant.
Can I just add to that a little bit? I think, one of the simple ways as we leave to remember that is we want everybody to get in line. There are some people who we want at the head of the line. And I think that, if we remember that, we won't forget to get in line to begin with. And when we say it's coming in initially at a trickle, I think it's important to remember, and I think Mel identified this, we're talking like every 7 days, we're getting another shipment. It's coming off the line. So it's not like, October 1st, then you have to wait till November 15th. So hopefully it will be seamless. By the time Mel remembers to get the time off and get his kids, an appointment, everybody will, it will be there. There won't be anybody saying, oh, don't make an appointment because you can't come in. So really want to encourage people to think of it as kind of it is a rolling, I think one of the questioners asked, it's kind of a rolling thing, but, we want everybody to get in line. Just remember who should be first in line.
Ginny Cornyn, City Club member. My question is really about the homeless population, especially in the city of Portland, but all around the metro area. Because of their mobility and because of their frequent contact with various other people, either in shelters or on the streets, is there any danger if they get vaccinated twice to their lives? In other words, if they decide that twice or 3 times in different locations is better than once, is that something that could be life-threatening to them and therefore needs to be part of the education around vaccination?
We are making plans to make special efforts to vaccinate the homeless. There is an immunization alert system that's in place that will be used for tracking this vaccination, and so we will be able to determine if people are getting vaccinated multiple times. It shouldn't be harmful to be vaccinated multiple times to the individual, but it's also not the optimal use of the vaccine. And so, what we find in the health services that we provide to the homeless is that the homeless folks are smart. They know what they need, and they are largely like the rest of us in most regards. So I don't think that I would expect to see excessive use of that service by homeless folks.
Well, we've come to the end of our program for today. Please join us next week for a discussion about healthy eating in America's youth. As we close, please join me in expressing our appreciation to today's speakers, LILLIAN Shirley, Mel Kohn, Gary Oxman, and Jean Baker. We are adjourned.